Good morning, everyone. This is again Dr. Farooq from ER Skill Lab and Bangladesh Emergency Medicine Community. Uh, Today, we have Dr. May Luin, who is an ST6. She's an ST6 cardiology registrar from East of England. Currently, she is doing her fellowship in University in Leeds on cardiac MRI. Welcome, May. It's really nice to have you today. Would you briefly tell us about your journey towards cardiology till now, where you're coming from, just for the audience? Thank you.
Good morning. Thank you so much for your kind introduction. My name is May Luin. I'm ST6 Cardiology Registrar, as Abdullah has introduced. So I started my journey here in this country around like 2017 and started my core medical training. We call it CMD. Nowadays, it's called IMT. So started my CMD, and then I applied my cardiology training for the ST3. And we started at ST3 at the time. Now they started as ST4. And so I got into the training straight away, thankfully, and started my ST3 to 5. After completion of ST5, I have applied this out-of-program fellowship in University of Leeds, which is in joint position with the Leeds General Infirmary Hospital, specializing in cardiac MRI, which I would like to be specialized in cardiac imaging when I become ST6 and 7. So at the moment, I'm in second years of my research, and I need to finish my 2 more years when I go back to clinical.
Wonderful. Thanks for the nice introduction. So let's dive into deep into cardiac emergency. I know this is in emergency department. Most of our audience are from Bangladesh background. They're all pursuing their career in emergency medicine, and obviously, cardiac emergencies are very core part of the emergency medicine. So that's why we're glad that we have you today. Um, Common things start to common things. So would you be able to uh, briefly introduce us on patient coming with chest pain, and if it is a cardiac chest pain, how do you know about is it cardiac or not cardiac, or how do you take it forward coming from the emergency department?
Right. So as we all know, cardiology cases are really common in day-to-day practice. Especially when you are doing on-call, you will see like most of 50% of cases with the cardiology and respiratory, and all others in acute medicine department in other specialty. So among all of them in cardiac cases, also again, chest pain is very, very common symptoms. You will see in emergency, you will see in day-to-day practice. So either they can be stable or they can be unstable. Okay. So so in our cardiology daily life also, we deal with chest pain a lot. When they present to the emergency department, I am focusing in this topic about ACS, which is acute coronary syndrome. So my chest pain scenario will lead to this side, and then we can talk about it more. Okay. So as you have mentioned, when there's chest pain, then we really need to know whether it's cardiac sounding or non-cardiac sounding. If it is, you can get the enough history, and because history is a key to start with. We all know that since medical school, we were talking about this history again and again, and that's the beginning as well, because this is very important. That's the thing. So the key is there in cardiology, because most people, if they don't know what this chest pain is like, so which means they didn't pick up from the history. So always make sure you got the history, because everything is in there. So talk to the patient properly, especially when they are stable, of course. So by doing so, we all already know that whether it's a cardiac sounding or non-cardiac sounding. For example, like if it's on exertion, or but if it is myocardial infarction properly addressed, they can have the cardiac sounding chest pain, which is kind of like squeezing, or like somebody is standing on the chest or sitting on the chest, stuff like that. So these are the clue, and also on top of that, you can ask other symptoms. Like this is especially for juniors. I'm just revising what we can see when we talk to the patient. So, for example, like there's nausea, sweating, fainting. Some people sometimes really even like loss of conscious, and also they start with palpitation and stuff like that. So these all can be compounding factor, but especially you categorize your pain nature so that we can know, okay, of course, if there's a cardiac chest pain. For example, like I gave you one scenario, which is really straightforward. We saw a patient in emergency. He is very young, fit and well. Young in this country means like he is kind of 55, in his 50, but we consider is young here, right? So I came in with like sudden onset of chest pain while he was at the meeting without doing anything, just having the meeting, and got a described in nature of this cardiac sounding, which is about like an hour, so that he came and present. And on top of that, when we expand the history, he has got this hypertension and also the diabetes. So these are kind of like something to be aware of when we consider about this chest pain, because this is kind of a cardiovascular risk factor that he has already got, although he claims that he is very fit and well.
Can I
So
just,
yeah.
as the people are gradually coming in.
Uh,
So again, just to summarize for the audience,
yes.
we have an ST6 senior cardiology registrar from East of England, Dr. May Lewin. We are actually discussing common presentation today on chest pain and their presentations. Obviously, Dr. Lewin, she mentioned that history is the key, and she was sharing one of the scenarios where a 50-something-year-old coming with chest pain. Uh, uh, just Thank you. If you just continue, is it the patient coming to emergency department, or why did you see this patient? Just to
A patient came to the ED, yes, emergency department.
All right. Yeah, please carry on. So
Yeah, sure. Like I said, after we have started, then we explore is there any risk factor, which is also another important thing. Secondly, after we explore about the pain, so we talk about this risk factor, and then you can go with others, for example, like any smoking history, etc., which is also kind of important for us. And then we move on. Within 10 minutes, we should have ECG for this patient with this scenario and history. So to be fair, in NHS, I would love to talk about how our day-to-day practice in cardiology. So in NHS, if the patient come to ED, usually our ED colleges, they have already done everything, like including ECG, like I said, and they have sent a set of blood tests, including for our cardiac biomarkers. Of course, other baseline as well, which has to be there, like full blood count, renal function, and BNP, troponin, lipid profile, etc., which is also important for the cardiac patient. So by the time we see these kind of patients, it's already like I said, it can be like seen by our ED colleges, so that we basically go through and review and pick up their history again and review these kind of investigation that we have already got. So okay, so we start with the ECG, which is a key in cardiology. So we pick up the ECG and have a look whether it's so basically, is there any ischemic changes or not? To be honest, this is what we focus. So in this study, for example, like if we are going to STEMI or non-STEMI route, I'll start with the non-STEMI because I'll tell you later how STEMI will present in NHS. So so if you see the ischemic changes, which is non-STEMI, non-AC elevation, then you got ECG diagnosis and you got history, and then you need to look for your blood test, especially troponin, and then we emphasize whether it's normal or abnormal. But usually, if there's ECG changes, we consider non-STEMI, and there's troponin data changes, they must be there. And so this job again, when they present, we don't get like 0 hours, so we have to do the job straight away anyway. And later we have like our regime, whether in an hour time or 2 hour time, we have to repeat.
And Dr. May, can I just
Yes.
a brief summary for the audience again? So
Okay.
thank you again. I know you're going through the case and describing anstomy. So for all listening from Bangladesh, so in UK emergency department, any patient come to the ED with chest pain or any cardiac sounding chest pain, it's automatic that the nurses do the blood test, ECGs within ideally within 10 minutes. Okay. And then depending on the bloods, and we do depending on the patient, of course, we do add the troponin and bloods and everything onto the patient. So of course, ECG is the key. So ECG will tell us upfront whether it is a STEMI or NSTEMI, which you are going to describe. But before that, just for the audience, because they're very junior, most of them are
Uh,
in cardiology.
all right.
If like a what is a cardiac sounding chest pain? What are the things in the history that trigger
Right.
you to think, oh, this is a cardiac sounding chest pain? Can you tell us briefly?
Of course, yes, I'm happy to. Yeah, as I've mentioned, it's very important whether it's cardiac sounding or non-cardiac sounding. For example, like if it's cardiac sounding, it's kind of like they would describe either constricting or squeezing, and also some people describe in like somebody standing on their chest. So it's kind of like heaviness. Sometimes they tell you like a discomfort, but if it just discomfort, if they said, then you have to explore more. You have to ask them more. You give the open questions, and if they answer that cardiac sounding, that's fine. If they don't give you that enough, because not everybody can describe, and they don't know about this medical term, and they don't know how these kind of things present and what we are looking for sometimes. So not everybody you cannot expect from them. So that in that case, if you cannot get the answer, just tell them straight away. So ask the right question. Is it like how's the nature of the pain? Is it squeezing? Is it sharp? Is it going anywhere? And so, for example, like if it is cardiac sounding, they would describe constricting, squeezing. Sometimes they go to the back. Sometimes they even say like elephant on my chest, which one of my patients described, which is that heavy. And also they will say that's a severity, which is also another important thing. You can ask them in here. When we ask, we say, okay, 0 to 10. So 0 is the very minimum one, and 10 is the maximum of your pain. So how would you rate your pain? So mostly in MI cases, it's very severe pain. So it cannot be less than 7 usually. So it can be more than that. And sometimes people say straightforward, like 10 out of 10.
Okay, so may I understand. So this is very for the audience, and this is very important to know what does cardiac sounding chest pain. As she said, some people even describe elephant on his chest. It's like very severe pressure in the chest, and then sometimes it goes to the neck or to the shoulder, left arm. Okay, even because they come in UK, they come by ambulance, most of them. So even paramedics say they give some GTN spray under the tongue. Sometimes they relieve the pain. Okay, so those sort of like triggers we look into. Also, not everyone has the typical pain. For example,
Mm.
elderly, frail, and diabetics, they probably have minimum pain. Also, sometimes they might say, "Oh, it looks like a gastroenteritis, like burning chest pain," or we think, "No, this is probably a gastroenteritis type of pain," but probably this is not. So. Knowing the cardiac typical pain, also aware of the atypical presentation, that is very key, and I am happy. Thank you so much. And also you mentioned about something, risk factors. Can you tell us about the risk factors that you concern?
Of course, risk factor to start with, I will check the past medical history, and especially like cardiac risk factor, diabetes, and hypertension, which are the key. And also some patients, they already known to have hyperlipidemia, and some of them, they are already on their statin.
Yeah.
So this is where you can get the clue, and also you can check their medication history and what medication they are taking, so that we can get a clue from there. And also we cannot forget about the family history. So we should actually ask how's their family like? Is there any these kind of diseases, chronic diseases in their family? And on top of that, which is personal history, kind of they are having like if it's alcohol, so how much amount they are taking. We have our own unit that we need to calculate, etc. But when you talk to them, you can ask them whether they are heavy alcoholic, or they are doing like occasionally or social drinking, which actually should be fine. And most importantly, smoking, of course, smoking, any kind of smoking, either how many cigarettes a day, whatever it is. If the smoking is yes, it's a yes. So which is smoking and heart will not get along well. So it's kind of a risk for that as well, which we mainly look for.
Thank you. Thank you, May. Again, welcome to the audience again. If you have any question while you're talking through, you can chat or actually you can ask on the mic as well. So we did briefly give you a background of history, cardiac sounding chest pain, risk factors. Assuming this is UK setting, so people already coming by ambulance, we within 10 minutes of arrival in emergency department, we done the bloods, ECG, and actually based on the history and ECG, we think out, okay, this which way this is going to go. Again, we're going to go talk about NSTEMI, so non-ST elevated MI first, and then come to STEMI. Please, Dr. Wayne, carry on with the non-ST elevation MI, and what are the ECG changes you're looking for there?
Okay, so in STEMI, so basically, if there's a ST elevation, then we call it STEMI. So apart from ST elevation in STEMI, then what are we looking for? So it's ST depression, especially what we are looking for, and also, of course, there's a pathological wave anti-inversion. So if I tell you, whenever we see the ECG, and when we see any changes, especially like ischemic changes that we are looking for, then we have to look which artery category that they are going. For example, like are they going like inferior, or like anterior or lateral? I'm not sure these audience are like familiar with this. So if I emphasize on like, for example, inferior, then we are looking for like a 2-3 AVF, this kind of ECG data that I have mentioned. Apart from ST elevation, like ST depression, pathological G-wave, anti-inversion, which we are looking for. If it is inferior, then 2-3 AVF. If it's lateral, then 1 AVF V5-6. And if it is anterior, we call it from V1 to V4.
Yeah, yeah.
Yeah.
I think you're right. So it depends on the ECG leads and changes, we can decide which artery or which surface of the cardiac surface area. So that's being infarcted. So you said 2-3 AVF is the inferior surface, lead one AVL V5 V6 is the lateral surface,
Yes.
and
Yes.
V4 is the anterior surface. And
Yes.
what are the arteries you allocate, on those leads? Which artery?
Yes. Yes, you are right. So that's going to be next step. So if it is inferior, we are especially talking about RCA, which is right coronary artery. And if it is anterior, V1 to V4, which is LAD, is left anterior descending. And then if it is 1 AVI V5-6, which is lateral, which is mostly circumflex. But I would say in medicine, there's nothing is never, So this, I would say, RC and circumflex changes can be overlapped, can sometimes be both. So these answer that we can get only when we go for angiogram. But basically, when you see the patients and we see the ECG, this is roughly how you can tell the artery.
Yeah, thank you. So let's say we seen the ECG. There are some ischemic changes, which is basically ST depression or T inversions, okay, and cardiac sounding chest pain. What is the next step?
Okay, so and now you got your cardiac sounding history and you got your ECG. Next step, I will check the blood test, like I said, biomarkers. which especially troponin in this case, of course. And if the trop is high, then you got like all your category that you can call this patient as a non-STEMI. Okay. There are other category that we have, which is kind of unstable angina and STEMI, which I will talk about later. So we're going to focus on this non-STEMI first. So let's say all these category, then we got the diagnosis of non-STEMI. So in that case, what are you going to do next?
Oh,
For
nice.
the type, yeah.
Yeah. So if the troponin is raised and the ischemic features in the ECG, this is likely NSTEMI. I know is depends on the labs and the countries. The cutoff value of troponin is different. What is your standard? What is UK standard for troponin cutoff and STEMI?
Right, that's really important. So even in UK, in between NHS hospital, we have a different cutoff value. We have a little bit changes there, but mostly, the cutoff value is like 14, which is 14 microgram per liter, if I'm not wrong. So this is depends on where you work, which hospital and which lab, and what kind of things that they use. So it's depend on that. Mostly the cutoff value is like it should be less than 14. If it's more than that, then we consider it's like high troponin. Of course, I will repeat later, but now you got some the clinical trial that you can call the patient as an STEMI. Yeah.
Fine. Thank you. And at the same time, so imagine if this is a real patient and
Mm,
ED we're suspecting NSTEMI,
mm.
do we start treatment right away or do we wait for the troponin?
Um, Good question. Very good question. So it depends that in that case, what I will do is if it is cardiac sounding, I will start the aspirin straight away. Yeah. And also, first thing first, we need to examine the patient, which is really, really important. I will emphasize again, really important. So if your patient, although it's non-STEMI, sometimes they even have like a really severe pain because you will never know. If you explore more, then you'll find out whether they are like very high risk non-STEMI or just severe non-STEMI.
That is a very crucial. How do you know this is a high risk and STEMI or low risk? How do you know this?
Yes. So we have like you can say like very high risk or high risk non-STEMI. So to start with, first thing first, like I said, you need to know your patient, see your patient, examine your patient. So if the patient has very severe pain, although it's non-STEMI changes on ECG, is there's no SC elevation. It's purely non-STEMI that you can say, but very severe pain, quite intense, and pain persists even like more than an hour. Even if the ambulance gave already started GTN, spray, etc. And also the other things, this is what you can see from the patient regarding the pain. And also you can check the parameters, for example, like how's the blood pressure, how's the heart rate doing. So in that case, you will know whether your patient, although it's non-STEMI, whether they have these kind of things. And like I said, and also another things to be aware of, which is from your history, how much risk that they have got. And have they got, for example, like although it's non-STEMI, have they got any previous MI before? And also have they got this kind of I'll blame to diabetes because which is very important. And this diabetes, hypertension, and high cholesterol, which is also really important. So in that case, if your patient has these kind of symptoms, very severe pain, and also it's kind of difficult to relieve, and stable parameters, and very high risk data, like I said, they might have a previous CAPG event, they might have a previous heart attack, and they might have a previous PCI. So these kind of things, all you can consider as a high risk non-STEMI. Sorry, I lost you. I couldn't hear.
Can you hear me?
Yes.
Sorry. What is the next step for the high risk group, high risk and STEMI?
Okay. For the next step, if to start with, your patient is your priority. So I will start straight away cardiac monitor, which is nonetheless, we don't need to even talk about. I'm sure my ED colleagues, if it is cardiac sounding, they will start the cardiac monitor anyway. It's really important that we need to know how's their rhythm doing and what their parameters doing. So we start the cardiac monitor, and then I will start the IV GTM for the pain to start with. Of course, we have to know the blood pressure anyway. So for the pain relief. And because it's really important that patients should be our priority, patients should be comfortable, this patient shouldn't suffer. So we have to manage about this pain. And also, like I said, even after GTN, you have to give like 60 to 90 minutes at least, whether they are responding to your treatment or not. If it is even not, I'm sure if it is 60 minutes, then we should have our throat back anyway. So while we are managing this, we are already started aspirin. But if it's this high risk patient having this, in that case, I will not be reluctant to start the DABT straight away. So DABT means you are antiplatelets on top of aspirin. We give the ticagrelor as well. Again, in that case, we have to talk about this ticagrelor and clopidogrel, which I'm not going to emphasize, but it depends on stress as well. So you can get the loading dose anyway. So give the 300 milligram aspirin and 180 milligram ticagrelor, and pain management and cardiac monitor, and review your patient anyway. So in that case, you will get your trop in the meantime.
All right.
Then,
Thank you.
yeah.
So I'm just going to summarize for the audience, guys. We started typical chest pain scenarios, typical cardiac sounding chest pain, bit of history, risk factors, and then of course bloods and ECGs. Okay, so in UK settings, as we mentioned already, everything is done by the patient arrives to ED within 10 minutes. So by 10 minutes you have the ECG, and you probably know the patient from the ambulance crew. If it's a cardiac sounding chest pain, ECG looks ST depression, T inversions. We Dr. May said we just don't wait for the troponin, give 300 milligram aspirin, of course. And if it's a very typical counting, high risk, very typical NSTEMI, high risk NSTEMI, and the patient is pain is still ongoing after GTN, you can give ticagrelor 180 milligram. Okay, so I think by 1 hour we're expecting the troponin to come back, and hopefully we can add on something else. So what do you do next after troponin comes back?
So okay, so now we got this top also come back. So I'm sure in this scenario top will be high anyway. So and let's say our top is high. So this is non-STEMI. And then in that case, what I will do next, again, I will review my patient. How is he doing? And how is the pain? How are the parameters? If he becomes stable, then it's okay. Okay means we don't need to be rushed into the lab straight away. This is what I mean. So we're gonna do the angiogram anyway, but we need to decide what are we gonna do.
All right.
Yeah.
What other things? I know you might, high risk me considering whether they go to cath lab or not. One of the things I think, at what point do you give fondaparinux anticoagulation?
Mhm. Okay, so if you know that this is a non-STEMI, we actually feel free to start our festivals. So we give DABT, of course. At that time, I think we don't have troponin in this scenario, isn't it? Now we got full diagnosis that we know all the parameters, we know our patients, so we are treated as non-STEMI. In that case, after loading dose, you have to give a stat dose of fondaparinux as well. Of course, if there's no contraindication, for example, like whether we need to calculate for the renal dose or stuff like that, that's what I mean. But we're not worried about giving the fondaparinux in STEMI, so you are feel free to give. So you have to give the stat dose for the fondaparinux for that day.
Thank you so much. One of the things I know, there's a scenarios, not scenario, real life situation. So let's say a lot of our patients, let's say we're thinking, oh, this is a typical high risk and STEMI. However, I'm making a bit of twist here. So, however, someone is already on warfarin, let's say,
Mhm.
already on warfarin. So, what drug should we give or hold for now? Or how do you manage the risk of bleeding?
Okay, this is very common. I'm glad that you raised this question. So, because you will see patient, loads of patient coming with that they are already on anticoagulant for some reason. Okay, let's say, like you said, the patient is already on warfarin. Then we have to hold off their warfarin, and I'm gonna change everything to the heparin. So low molecular weight heparin, and then we need to calculate the dose and change it to that. And during the patient stay, we're gonna hold off warfarin.
And one other things, in those patients, do we still give fondaparinux ticagrelor or do we hold this fondaparinux?
So in that kind of patients, I will give dual antiplatelets plus their dose of low molecular weight heparin.
And low molecular weight heparin.
Yeah,
Don't give fondaparinux.
yeah.
All right. Thank you guys. For the audience, just to summarize, we're talking about the treatment cocktail that we use in UK for NSTEMI, non-stability MI. Let's say it's someone high risk and high risk NSTEMI when we have evidence of typical chest pain, ECGs. We can actually, as Dr. May said, we can actually start on the treatment if we really think this is a cardiac pain. So by treatment, we think we give 300 milligram of aspirin, 180 milligram of ticagrelor, okay, and we can also give fondaparinux, which is an anticoagulant, 2.5 milligram subcutaneous fondaparinux in UK settings. However, if someone is already on anticoagulation, don't give fondaparinux. There's a high risk of bleeding, and actually we can, if someone is on warfarin, we have to switch to low molecular weight heparin after calculation. So those are the things to remember. So always think about the bleeding risk on the same patient. Where is there, other than warfarin, is there any other contraindication for fondaparinux for any patient?
We don't give fondaparinux in STEMI patient.
No.
That's the only thing, yeah, because the reason is we have to use loads of heparin when they go into the lab
Yes.
and to be patent when we do the procedure. So in that case, we're not gonna give fondaparinux. Yeah.
Thank you. Thank you so much. So let's find let's say we did that patient, we started the treatment, the troponin came back anyway, and this is a non-STEMI. So what is the next step down the line?
So next step, so currently the patient is on monitor, and after we start the pain medication, a patient becomes stable, pain becomes better after 60 to 90 minutes. In that case, usually if the NSTEMI, our guideline says like within 72 hours during their stay, then we have to do the angiogram. Okay. But like I said, there are some exceptions, like high risk non-STEMI and very high risk non-STEMI. For example, they have like kind of that repeatedly getting the symptoms, severe pain, and dynamic ECG changes associated with this pain, and patient parameters hemodynamically become unstable. In that case, we have to do it like within 24 hours for the angiogram.
Okay.
And yeah.
As you said, even in STEMI, normally they have angiogram within 72 hours, but someone is high risk, unstable, severe pain or becoming unstable, then you have to do early other than.
Yeah.
So, so even NSTEMI at some point for the audience in Bangladesh, they high risk NSTEMI also gets the angiogram at some point with hours or less, depends on the situation. Okay.
Yes. Yeah.
And one of the question from the audience saying, do you give blockers or statins?
Sorry again.
Beta blockers or statins? Do you give them in STEMI SCA?
Well, beta blocker is our friend. We really love beta blocker.
Yes.
Everything beta blocker can fix. But when your patients are just presented with a non-STEMI, we're not gonna start at the moment, but they have to go home with beta blocker, no doubt.
At the time of discharge later on, okay, we
Exactly. Yeah.
give it acutely on high risk STEMI. Okay.
Yeah. And of course, statin as well. We love statin as well.
That's statin. Okay, but they can be given later.
Yeah, could I please emphasize for statin as well in that case? So if it is non-STEMI patient that you have admitted the patient in your drug chart, you should prescribe your aspirin. Then now it's like 75 milligram OD, and then your ticagrelor, which is 90 milligram BD, and on top of that, you have to give this atorvastatin, which we use commonly in NHS, which is like a high dose, unless there is any contraindication. For example, like any problem with the muscles or liver, if there's no issue with that, then we give 80 milligram.
Mm.
Which is also high dose that we start straight away. But for your beta blocker, I will just see how is the rhythm like. If there's no bradycardia as such, then you can start from low dose. For example, like I'll prescribe bisoprolol 1.25 milligram OD once a day. And also this dose, if the heart rate allow after the procedure, then you can even increase it and make sure these medications when the patient should go home with. Yeah.
Thank you. So you said after the loading dose of aspirin, then you continue as 75 milligram
Yeah.
aspirin a day, and then
Yes.
you said no, you said
Ticagrelor. Ticagrelor.
milligram BD, right?
90 milligram BD. Yes.
Then statins 80 milligram, I think
Yes. 80 milligram.
once a day.
Yes, and by bisoprolol, if there's no bradycardia, then
Okay.
you can start like 1.25. Because you will never know. Some patients very sensitive when you start this kind of medication, either their blood pressure or their heart rate can be sensitive. So you can start from the very low dose, which is the safest, and also beta blocker is good for the heart. And then we see how. Yeah,
And also question is 80 milligram statins is high dose. How long do you continue 80 milligram?
atypical statin with high dose.
80 milligram of atorvastatin.
Yeah. So when they admit that, then we start with a 80 milligram statin. And also depends on that we always need to chase their lipid profile as well.
Yeah.
Some people even when they present, and they have like a very sky high one, which we don't like. So like I said, we start with a high dose, and then when we reduce to 40 milligram, then we always aim and especially look at our LDL.
Mm.
So LDL cutoff point is 2. We want it like less than 2 if it is an ACS patient. So so this is how we titrate the statin dose. Yeah.
Okay. And ideally, what are the dose they go home with? What dose they go home? What the tablet?
So yeah, so when they admit that with non-STEMI and when they discharge, they go home with 80 milligram in the beginning. Yeah, and like I said, and they we repeat, which is like 6 weeks to 3 months, it's supposed to be, and then we adjust those.
Okay. So thank you. Thank you. Right. Somebody just mentioned in the text that he's asking Dr. Ibrahim, saying,
Mhm.
what about the risk stratification scores in ED, like heart score, TIMI score, and how reliable they are? When do we apply those scores?
Mhm. Well, I mean, these schools are good because they can guide you to certain extent that you will have some idea how about these patients and how risky these patients are. But especially, for example, like we are talking about now in emergency setting, and these are not stable patients and presented with the ACS. Rather, if it is in a clinic or if it's stable patient, then I will use this kind of score. And if it is in ED setting, for example, and also on top of that, you can use the grace, like whether they are like more than 140, etc. And then if you're not sure, then by doing this, then you can have some idea these patients are high risk. But they are not, like I said, they are not directly applicable to our like ACS management, which is according to the guideline. Yeah.
Thank you. I think you're right. So those scoring are for the low risk chest pain, not
Exactly.
not a,
Sleep patient, clinic patient, low risk chest pain. Yeah,
exactly. Someone is walking in the clinic or GP, and you're thinking history-wise is low risk. So
exactly.
decision making. I think this is a very good question, Ibrahim. I think we apply those scores for low risk chest pain who likely going home. Okay. So
Yeah.
likely coming to high risk and coming to stay in hospital and PCI, we don't apply those scores, and that's the thing. Uh,
Mm-hmm.
okay, so he said thanks. So yeah, so again, we probably come back to this later. So anyway, so in terms of NSTEMI management, so far you did mention about the risk stratifications, high risk NSTEMI, initial
Mm-hmm.
pain management, also the drug details. Is there anything else we need to know from the ED perspective from NSTEMI?
Mm, um, I think ET colleges are doing quite good, so I don't have any particular comments on that. I'm sure they all are aware of what I have emphasized here. Yeah. I'm really glad that they are on already on cardiac monitor when they
Oh yes.
have been referred to us, you know. So because the thing is this kind of non-STEMI can come with like cancer goes arrhythmia, which is one of the high risk factor which we are looking at. In this kind of patient, they have to be rushed to the lab when compared to others, you know. Yeah.
So there has to be in cardiac monitor, and I did mention IV GTN infusion for
Yes.
minute. So
Correct.
make sure they have enough. Is not aspirin is initially may help, but if there's somebody's ongoing pain, you don't keep on giving GTN spray. Put it
Exactly.
maybe a GTN infusion for
Yes.
ongoing chest pain. I
Yes.
would. So let's tweak the scenario a bit. Let's say ECG is ischemic changes, but
Mm-hmm.
is normal
Mm-hmm.
troponin. So
Mm-hmm.
what do you do those patients? What do you do with those patients? Trop is normal.
Okay, so if the trop is normal means it could be our first trop. So you have to revise the history, what time that they actually started this kind of symptoms, you know. Sometimes the patient just present to the ED, but they have been having this kind of pain like off and on. And one day I like doing exertions or sometimes they take rest and it relief and they didn't present it to you. So in that case also, which is kind of like we would call it, and maybe they have undiagnosed chronic coronary disease. So in that case, it is one of the possibility. And second thing, we can never miss that because we have to repeat the trop anyway. Like I said, after we visited the history, you will know the timing of the pain. So you have to know like what time is your trop, what time is the pain, and how is the patient now, and what time are we gonna repeat, and we have to chase again. And if it is really cardiac sounding and ECG changes, although first stroke is normal, I don't think I will let the patient go. And they are repeat their another stroke and also with the monitor.
Very important question. Tell us a bit more about this timing. So onset of pain, first stop, second stop. Tell us a bit more about the timing, how this timing helps.
Okay, so the timing is really important. I'm glad that you emphasize that. So in our second job, we usually do it like within 1 to 2 hours, and it can be 3 hours as well. For example, especially which is even after 3 hours, if it is normal and no changes, then it is less likely. But the guideline said up to 6 hours at least, that we have to make sure that the patient has got this normal blood test and most importantly, no repeated chest pain again. If they keep having chest pain, although your troponin is not that high, then I won't be like able to let him go for the safety reason, because there are a few exceptions. You know, like I said, I'm in medicine, and it can happen as well. So in that case, I will monitor for at least like 6 hours. I think it's really important.
Thank you so much. You really mentioned some key points. Even though, guys, whoever is listening, just remember, even though the troponin is negative, the patient is still in pain. I
That's
we
a red flag.
Exactly. This is a red flag pain. So don't send them home because we might miss something there. So even the guidelines say, oh, repeat troponin and send home, this normal, probably not. So I would say keep them in the hospital. However, those patients with repeat troponin negative chest pain, we can do another troponin, obviously. Do we consider them as unstable angina, or how do you label them? Unstable angina?
Yes, if it's if after you have repeated, sometimes we repeat like we repeat first drop, second drop, third drop. So or we repeat like a first drop and second drop. Usually we do have that drop anyway. So if it is all normal but still have a chest pain, very cardiac sounding, you can either see like ECG changes or not. So we would diagnose this one as an unstable angina with this pain. And of course, in that case, I mean, like if you want to use the score, you are like very welcome to use anyway. So in that case, then we will find out how risky this kind of patient have a high risk factor or stuff like that, which is also very helpful. So if there's a pain continue, in this case, we diagnose as an unstable angina, then we can do the inpatient investigation. Although it's not very urgent, then we should do the angiogram at least, rather than like outpatient CTC or whatever, which is not recommended even in guideline.
Thank you. Thank you so much. He did mention that even patient with repeated trop, second or third trop is negative, query about unstable angina, and those patient needs to stay in and may even have an angiogram. Just to
Yeah, may even have it. But before that, first thing first, we always do the echocardiogram. So
so,
by doing echocardiogram, what are we looking for in this kind of patient? So we're looking for any regional wall motion abnormality. And also, of course, by doing echo, we can see is there any other compounding factors or any structural heart disease, which can be causing the chest pain, you will never know. So like I said, first thing first, we will repeat the ECG and see any dynamic changes. And also we'll do the echo, which is a very first line, very helpful, very informative as well. So these are the factors that we are looking for in echo.
thank you so much. Thank you so much. So eventually, all patient with chest pain, if it is low risk or even ongoing chest pain, is troponin, if they get an echo, make sure there is nothing else structural
Mm,
that's
mm.
causing pain, and then maybe end up in PCI or angiogram. Thank you so much. So I think chest pain can, again, we are actually, yeah, we are talking about cardiac sounding chest pain going towards NSTEMI, unstable angina this way, and also based on the ECG, as I'm saying, with our key demarcation is the ECG. Okay,
Mm-hmm, mm-hmm,
so you said if it is not ST elevation, this is NSTEMI or unstable angina, and then we
mm-hmm,
this way. And
mm-hmm.
and also all this coming from the cardiac sounding chest pain, risk factors and everything.
Mm-hmm.
Would you able to uh, give some ideas on STEMI side? So what happens someone is ST elevation? We did discuss, I think, briefly cover almost everything in
Yes,
broad category on NSTEMI.
yes.
Let's talk about a bit of STEMI and tell us how things evolve in STEMI.
Mm-hmm. Yes. So if it's STEMI case, uh, for example, usually in NHS, I would say we have already trained our ambulance crew as well. So if it's STEMI ECG that they see on the ambulance, then they usually inform straight away to the PCI center and also to the hospital where there is primary PCI service, even in out of hour as well. So so basically, they will go directly there. So what they do, what we expect them to do, so they have already given, like I said, like aspirin 300 if the patient can take anyway, and also they have to be on cardiac monitor, and they came in with a defib, and in that case, the guideline said for the primary PCI we have to bypass ED rather than stopping in ED, unless you don't know which is STEMI. In that case, we have a few bleed from the ED that we sometimes like probably the STEMI is not very pronounced, that they didn't pick up on ambulance. In that case, you might have a call from ED. But in the typical scenario, if it is STEMI, should go directly to the primary PCI lab. So me as a cardiology registrar, we got a call from ambulance, and they gave us an estimated time of arrival, which we go and pick up at the entrance of the hospital. We're not gonna just sit down and wait for the patient. Our lab is ready. The lab team is informed, and we inform to the CCU, make the bed ready, and we as a registrar, we go to the entrance of the hospital, wait for the patient. Sometimes they come in with air ambulance, sometimes they come in with a chest ambulance. So we just jump into the ambulance straight away and ask the history on the way when we are going to the lab, because the time is master. The time is master. We cannot be late. So in that case, there are a few questions might come up because we have this kind of scenario even in the UK, whether you can reach to the primary PCI center or not. So it's supposed to be, according to guidelines, supposed to be less than 120 minutes that you have to be there to the primary PCI center. So if the area of the patient where you pick up, which is far from the PPCI center, there's another scenario which can be thrombolysis.
Thank you.
I'll touch base. Yeah.
Just gonna summarize for the audience. I think
Yes.
we are talking about STEMI, estimated MI in UK settings.
Yes.
Obviously, it's usually is picked up by the ambulance crew sometimes, and they can actually transfer the ECGs to nearby PCI center. And as you said, the ideal timeline from the onset of chest pain to the PCI center is less than 120 minutes. Is that
Yes.
okay? And then, as you said, as a cardiac registrar, you are alerted before they arrive and ETA
Yes.
anytime arrival, and then you actually meet them at the front door. Actually, you go in the ambulance and see the patient from there.
Mm-hmm.
Okay.
Mm-hmm.
And can you tell us what happens when you see the patient?
So when we see the patient, we jump into the ambulance. We talk to the patient, talk to the crew. At the same time, we are looking at the monitor and we are seeing the ECG. We are doing everything simultaneously because, like I said, time is very important. And also, we make sure they give aspirin ticagrelor on the way as well. As I mentioned before, you are allowed to give aspirin ticagrelor. I mean, dual antiplatelet, either clopidogrel, aspirin clopidogrel, or aspirin ticagrelor. But we don't need to give fondaparinol for the STEMI, like I said. So I have to make sure what medication they have given, how is the patient doing on the way. And by the time I see the patient, I will check with the patient whether they are still in pain and have they given any, they usually give either GTN or morphine on the way. So I have to make record of everything literally. And also how's the rhythm wise by the time they are coming and their journey and stuff. So these all are happening like simultaneously by the time we are pushing the trolley to the lab. Yeah. So we're not gonna stop anywhere. I just straight into I will help them and push the patient straight to the lab. So if they are this kind of stable, this is the best scenario of STEMI that we will go straight to the lab because we already informed to the lab as well. They got the bed in CCU, everything for NHS. So this is very straightforward STEMI. But we have more complicated scenario as well. I don't know why how these juniors will have to hear about this. So for example, if the patient come with an arrest and come to us and come by the ambulance, that's another scenario. And also there are some STEMI patients, but the ECG changes are sometimes not very stable and typical STEMI. There are a few exceptions which I want to emphasize as well. So for example, if it's not STEMI, but there is ST depression that you can see on normal ECG, which is posterior STEMI. I would love to emphasize this as well because we treat as STEMI in this posterior MI. In that case, you will see like especially V2 to 3, but you can see like V1, V2, V3 ST depression in STEMI ECG, which is posterior MI. If you want to see ST elevation, you can do like a V7 to 9 ECG, which I don't think sometimes not possible on ambulance, so they don't do that. But being as a frontline doctor, you have to know about this, so you have to pick up. Yeah, that's one thing, which is not straightforward, which can be easily missed even in the big center as well. So have to be careful about that, I think, because sometimes posterior MI has a poor prognosis, if you know that, because they will never come alone because they can't be combined with either inferior or lateral. So which means which there's an extension which is a big infarct, so it's more risky. So which is important.
Thank you so much. And it's a very, very interesting topics you're heading into now. As you said, sometimes there's not a straightforward MI. It
Yes.
get pre-alert, everybody's ready, cath lab is ready, it's within the time frame. Sometimes they
Mm,
different way, different forms. One
yes.
mentioned that someone with cardiac arrest and
Yes.
ROS, they can have acute MI. So, I mean, that's something, the post cardiac arrest MI. Uh,
Mm,
and the other one is a posterior MI, which can be easily missed. As
mm,
V1 to V3, sometimes tall ER.
mm,
It should be a V7 to V9 posterior leads, but it's not always possible, but we can suspect all the time.
mm.
Just to have you give, we actually reaching 1 hour window,
Yeah.
another 5 minutes left here.
Yes.
Are we happy to continue a bit more, or what do you guys? People are asking questions, so I'm gonna be answering this bit more. Is it okay, Dr. May?
Yeah, yeah, there's a question. Yeah, please.
Okay, so one question, Dr. Imsa, do we give antiplatelet to STEMI patients even if they are going to immediate PCI? I think you just answered the question, isn't
The
it?
answer is yes. The answer is yes. Yes, we do give dual antiplatelets for STEMI patient. And they can give on the way, like I said, the loading dose of aspirin, 300. If it is clopidogrel, 300 to 600 that you can give. If it's ticagrelor, 180 milligrams stat that we do give. And we don't give the injection. We don't give on the brain loss because it's a kind of synthetic heparin, which we're gonna use during the procedure, which we will need most of the heparin at the time, so that we don't give that for the bleeding risks.
Okay. And another tricky question, I think Ibrahim asking a very, very important question. So, how do we know this is not an aortic dissection causing this infarction?
Right, okay. So looking back to the scenario, I have to start from the beginning, which is a history where you can easily get a type of the pain that, I mean, like I said, like common things are common. We do see early taxation, of course, but we have to combine all the information that we get. How is the pain like? But because the aortic taxation pain is a bit different from MI, but sometimes, of course, I agree, it's very difficult to differentiate, because especially if the patient cannot tell you the nature, etc. But this is one of the things that you need to consider history, and also again, the compounding factors. Like I said, in past medical history for the aortic dissection, if you suspect, of course, you have to look for any other thing. For example, like if the patient morphinite features, or is there any connective tissue disorder before? Is there any other past medical history that they have been diagnosed, which can be a risk factor of the aortic dissection? And the other things, you're gonna do your examination, so you have to feel the pulses, whether they are equal or not, and how your blood pressure changes and equal or not, and how's the femoral pulse, and of course, is there any neurological features that you might see in this kind of condition? And when we move to the investigation, when I see the ECG, if it's inferior, which is more likely associated with the aortic dissection rather than other area, so this inferior ECG change, which is not very straightforward always, because I didn't emphasize at the beginning because I want to start with a typical scenario. But now you raised this issue, that's why I have to talk a little bit more about. Because in inferior ECG, we have to look for some other differential and also compounding factor, which is one of them is aortic dissection, and also inferior you have to look for any heart block because RC supply the AV node, and also again in inferior there might be some extension because like I said, circumflex and RC they might have some extension, and also inferior can be like there is a lateral extension, etc. And also like I said, neurological features that you have to think about. Yeah.
Thank you so much. I think it's a very good question. It's not uncommon, but it's a very rare scenario that you have a
Yeah.
section presenting as an inferior MI. As you
Mm,
MI is very common in aortic dissection. However, that this we need to rely on our history, examination findings, ECGs, and everything, and plus or minus acute dissection feature that it includes typical
mm,
like tearing, going to the back, sometimes
mm,
some other like neurological features. So all this history, everything, and then we have to actually make a clinical judgment. To be honest with you, it's not state.
mm,
We can, so, we can always go back and review our diagnosis. And
mm,
so I think in ED perspective, there is another tool we can use sometimes using the ultrasound to have a
mm,
of dissecting. Some
mm,
can see the dissecting flap if you put the probe in suprasternal notch or
mm,
on the aorta, depends on where it's coming from. So it can help. Sometimes X-ray can give you something, but
mm,
as I'm saying, these are the gray areas, but we
mm,
try our best based on the resources we have and the time.
mm,
Thank you. So I think I have one other question. This
mm,
Let's say this is not a typical STEMI and non-STEMI. So let's say because the other day in ED we have a patient with VT cardiac arrest for a long time. Okay,
mhm,
so I think 2 hours HEMS, like HEMS team, 2 hours in the pre-hospital setting. They're doing the manual, not the Lucas chest compression, and
mhm,
is shocking, and then P, and then get to PF and VT. When they arrive to ED, it's also VF and VT cardiac arrest for another
mhm,
hour.
mhm.
Fine. So it's like, and then we put the echo. Then there are some cardiac movements. So those scenarios, if you're thinking it's a cardiac origin, cardiac arrest, it's the cardiac sounding, so it's a shockable rhythm, and
Mhm,
it could be MI causing all this.
mhm.
Um, in ideal scenario, so do they go to PCI when we are having chest compressions, or what are the what are the cardiology guideline from these scenarios?
Right. Yeah. This is my, as I mentioned, this is my next step. This is a worst case scenario of the STEMI, which is not straightforward. Came in with a cardiac arrest. In that case, they're not gonna go straight to the lab. They will come to ED first, and then we're gonna come and see in ED whether we should take the patient to the lab or not. This is where we decide. So what we do is we predict their neurological outcome, and we have a score called CHECK, which is like to predict the neurological outcome if we revascularize the patient, what will happen. So that score include like their age, and also like you said, they have a shockable or non-shockable rhythm, and also how many adrenaline that they have received. I mean, the higher the worse, and also shockable rhythm is better than non-shockable rhythm. And age-wise, also if it's older patient, which is not good, and also we check them their pH level as well, how much acidosis they have, and how low is that. These are all the criteria that we use. And also, of course, we do need to know where they actually got arrest, and also how many cycles of CPR, and how many minutes of downtime before they got everything, and how long does it take, like at the moment that they got the CPR. So these are all the factors that we use and to predict the score. So obviously, like I said, a higher score, which is not good, and we do have that kind of scenario that with a very high score in this, and when we predict the outcome, which is very poor, and we didn't take the patient to the lab, and we just break the bad news, the patient family at ED itself. And of course, our interventionist consultant, this is what we do at the front line, and then they come and decide according to that, and then they break the bad news to the family, which is what happened. And also, in the on the other hand, for example, like the patient is very straightforward, and downtime is not that long, and seems like that we can revascularize if there's a chance. Then we have to take the patient to the lab. In that case, what we do is we use a machine for the chest compression, and with that one, we go into the lab. If we
Wow.
need, yeah, we do. If we need, we do. If we don't, and sometimes, arrhythmia like comes and goes. Sometimes you still need chest compression. So if we still need chest compression, we do. We go into the lab with this. If not, then we put a standby anyway, but we go to the lab. Yeah.
Thank you. It's a very complex question, but thanks for
Yeah.
giving us a brief idea. So, guys, we are talking about patient with cardiac arrest and likely because of MI, and mainly they are coming with shockable rhythm, and
Mm-hmm.
they get prolonged chest compression. We have a machine called Lucas that the machine chest compression can keep going, so you don't need a human compression anymore. So we call
Mm.
it Lucas, and actually, as Dr. May mentioned, they can, if they qualify, they can go to the cath lab with Lucas on or manual chest compression, whatever it is, and they can actually do PCI on that machine. So the ongoing chest compression. This is really interesting. I'm getting excited. So
Yeah,
the other
it is. Yeah.
did mention about a scoring system that you predict whether it's new about neurology. What is the name of the scoring system?
CHAP. CHAP.
CHAP.
CHAP. CHAP. Yeah.
Okay, so CHAP, CHAP is a scoring system that I heard today from Dr. May that we use from the cardiology point of view to predict the outcome, neurological outcome of that prolonged cardiac arrest, likely. And thanks so much. The next question related to this: when is there any option for ECMO in these scenarios? ECMO.
So we don't usually start ECMO, and at this stage, we try to keep everything like possible stable as like supportive to get the procedure done. Okay, so it depends. So after the procedure, if the patient need ECMO or supportive things, then we will decide whether they will go to the ICU with the cardiology and ICU team and manage together, or they will just go to the CCU, stuff like that. Yeah.
Thank you so much. Well, I think we have very interesting discussion today, few questions, and we actually went to the extreme of STEMI and or give overview of NSTEMI pathway. Thank you, Dr. May. I think we just over 6 minutes of 1 hour window.
Yes,
I don't think we are able to cover everything in cardiology medicine today.
that's true. Yeah.
I think let's see. Okay. Okay. So a lot of people are giving you thanks because of this, clarification. I think even I clarified a couple of questions with you. I think cardiology emergencies are core part of emergency medicine, and
Mm-hmm.
all ED doctors should know the idea, around it. So I think we need to invite you again for another session. Definitely, there are a lot more to talk about. Uh,
Yeah.
Mm, and there are other things. I think we didn't even touch heart failure, or that wasn't we supposed to. So
Yeah.
STEMI and
Because
STEMI.
it's a very like a huge topic, to cover things in and within 1 hour, and yeah, we can talk about later.
Obviously, we definitely want to talk about a bit more. I feel the audience are getting more interested. Even myself are getting more as like a fast and experience from inside from your end. So,
Mhm.
audience, again, just to summarize, today we discussed, yeah. So audience are saying that they are keen to hear more about this.
And I'm sorry to interrupt. So if we talk about heart financing could be later. I mean, for this, I just want to touch only one thing, just very briefly. And for the STEMI, I talk about this posterior MI, and also there is something we call it Wellen syndrome. Not sure Junior are very familiar with that, which I don't want them to miss that, because if there's any deep T inversion or any biphasic T in V1 to V3, you need to be very careful because it's going to be STEMI equivalent. So I just want to highlight, although it's not STEMI, but if there's a ST depression called posterior amine, or if there's biphasic T or very deep T inversion, that one also STEMI equivalent, we call it Wellen syndrome, just for you to be aware of. Yeah, at least they can escalate. Yeah.
And this is a very good question. You did mention the Wellen syndrome, and this is something we need to be aware. We ought to
Yeah,
be deep to inversion and cardiac sonic chest pain, and
yeah.
that qualify. Is it LED or what artery does it in?
This is LED.
LED, and they go.
It can happen in other vessels as well, but mostly LED. Yeah.
And when you said it, Wellen syndrome, the other topics in my head. How about D Winters T wave? What is?
Yeah, the winter, even like myself in my whole life, I hardly ever see, but I saw Welland. I
Oh,
saw Welland. So that's why if there's very deep T wave, T inversion in these leads, especially anterior leads, and then you have to be careful. That's it.
and what are the ECG criteria for D Winters? What sort of ECG changes you
So
see?
that one also can come with a very deep inversion, and also like I said, and we have to look the whole picture, of course, because this kind of deep inversion in these leads can be cardiomyopathy as well. You will never know. That's why we have to take the full picture. But when we talk about STEMI, we cannot ignore them as well. That's it. Yeah, that's it. I just want to remind. Yeah.
So I think the question is, how do you know this is the Wellen syndrome is not NSTEMI? Whether it's how do you differentiate this is Wellen or not NSTEMI?
So if it is Welland, if it's biphasity, then in that case, that you're not gonna see an anstomy. If it is deep T inversion, of course you can see in anstomy as well.
Yeah.
But at the end of the day, like I said, at least if you recognize this is the ACS, and also again we have to take into the consideration of the full picture of the patient. If the patient is the pain is very severe, and if it is continuous, if it is unstable, if there's dynamic ECG changes in those leads, then of course I'll give priority, because it can be non-STEMI or it can be the STEMI equivalent. You will never know. So you have to escalate that to the lab.
Yeah, I think it's a good point. So even though, yeah, it may look like NSTEMI, but if it's a deep T inversion with T
Yeah,
and
yeah. Yeah. I mean, it's very rare. It's very rare, but I cannot just ignore when I talk about STEMI.
always double check whether I'm missing Wellen. So
Exactly. Yeah.
be more cautious than relaxed. Okay, so
Mhm.
it could be Wellen. Just think Wellen and then chase, and opinions for Wellens
Yeah.
because it's not a straightforward. But if
Yeah.
you're can be, uh,
Hmm.
thanks for the last minute input for this Wellens syndrome, which is not uncommon. Uh,
Yeah.
and we did briefly covered the overview of the STEMI and STEMI pathway.
Hmm.
So much, Miss Dr. May. I think I would love to invite you because other topics needs to be covered as well. And
Yes.
happy, then we will have to schedule for another session and another time. And
Hmm.
if anyone has, no one has any other question, Dr. May, do you have anything for the audience in general to say at the end?
Yes, thank you so much for giving your time and joining. I'm really honored to be here, and I'm very happy to share my experience. And also, if you have any questions, feel free to reach out to me via the email. I think Abdullah has got my email, and yeah, happy to be here at the end.
Thank you. And also, everybody got the emails from my side as well. If you have any question later on, just pop in an email. I'll ask Dr. May. And obviously, she agreed, we're going to bring her back for further cardiology discussions. Uh, so far, so good. Guys, thank you so much. And thank you, Dr. May. It was
Thank you.
bye.
Take care. Take care.